Do you have my voice?
Just a test. 1, 2, 3. Do you have my voice?
Yes, yes. Do you have my voice, Dr. Abbasian? I have your voice. Do you have my voice, Dr. Abbasian?
Okay. Dr. Elizabeth, do you have my voice?
Yes, I have your voice.
Yeah?
Yeah, I have my voice. Do you have my voice?
Yeah. I have a voice. Very good. In the name of God, the most gracious, the most merciful. Hello, everyone. Welcome to Umbilical Dislocation webinar. My name is Alireza Abbasian, medical doctor and PhD of Tehran University of Medical Science. And I'm also head of Department of Traditional Medicine. I'm thrilled to see so many of you joining us today from different corners of the world and also from different corners and different parts of Iran. I'll be your host and guide throughout this exciting journey. In today's webinar, we're diving deep into umbilical dislocation or in some text, umbilical displacement. Whether you're a seasoned professional looking to expand your knowledge or someone new to the field eager to learn, this webinar is packed with valuable insights and some practical tips. Over the next hour, we'll cover definitions, signs, and symptoms, and treatment of umbilical dislocation. But this is far more than just a one-way conversation. I encourage each and every one of you to actively participate, ask questions, and share your thoughts in the chat and QA section. In the last 15 minutes, at the end of the webinar, we have this Q&A section. Remember, learning is a collaborative experience, and together we can make this webinar even more enriching. So let's get ready to explore the fascinating world of dislocations and embark on a journey of discovery and growth. Before we kick off, let me quickly introduce our amazing speaker. Dr. Mehdi Alizadeh is one of our best colleagues in traditional medicine faculty. He is also MD and PhD in traditional medicine. He brings a wealth of knowledge and experience to the table, and I'm confident that their insight will inspire and empower you. I hope we can continue these webinars. All right, enough with the introductions. It's time to dive in, right in. But first, a quick reminder to silence your phones, grab a notebook and pen to jot down any important points, and get ready to engage with our incredible speaker. At the end, I appreciate a praise to raise team of Tehran University of Medical Sciences to prepare infrastructures of this webinar. Once again, thank you all for joining us today. Without further ado, let's begin this incredible learning adventure together. Dr. Alizadeh, you're ready.
Thank you very much. In the name of God, most gracious, most merciful, I say salam to all of you, which is means God's peace be upon you all. And I thank my colleague, Dr. Abbasian, for his kind introduction. And I hope this seminar, this speech will be useful for our friends. Okay. I will start my speech about umbilical dislocation or displacement. It's an example of Persian folk medicine mostly, although it has been discussed in the manuscripts, and we have manuscripts about it, but not too much is discussed in the manuscripts. This session is mostly centered on my own experiences and what I have learned from folk medicine in Persian medicine. And although I have used integrative techniques to approach the issue also. So it's kind of visceral manipulation in Persian medicine. Okay, let's go to the next slide. Okay, what is the importance of the navis or the umbilicus? Why is it so important? We know that the navis is a remaining of a connection with the mother, the connection of the embryo. It's a feeding line. It's a expulsion line that it was a fundamental source of nourishment and route of excretion also in our first 9 months of life. So after the disconnection from after birth, there are still connections inside, behind the abdominal wall, connecting the navis to different organs. But this connection is being held by numerous fascia and muscular connections in all directions. So we here have a picture of the abdominal wall, but the posterior view, like viewing from forward, looking forward at the posterior of the belly wall. So it's like we have opened up the belly wall and we're looking forward to the posterior of the navis. So we see different connections. Do you see my mouse, my pointer, Dr. Abbasian? You see my pointer on?
Yes, I see your pointer. That's okay.
Okay, so there are connections to the liver, but it has become a ligament. Now it's not a pipe anymore, or it's not a tube anymore. It has been turned into a ligament, and there are also ligaments connecting the bladder and other parts, even the uterus in the female, and also we have fascia of the different fascia of different muscles, and also we have the muscles connecting to the navis. So we see these connections in different books. It has been bolded and paid attention to these connections, that it causes different problems if there are problems in the navis. So when we have a dislocation in the navis, it affects the organs that are still connected to the navis via the muscles, via the fascia, and via the ligaments, and so on. Okay. Now, what is naval displacement or dislocation? what do we mean about naval displacement or dislocation? It's all, in my point of view, it's all about spasm, which is called tashannuj in traditional Persian medicine literature. Tashannuj or spasm is the tightening of different tissues, and these tissues are muscles or ligaments or fascia. So you might ask that, okay, we know that the muscle is it's made up of actin and myosin filaments that go into each other and make contraction. And when that contraction is stuck and there's not enough food or blood reaching the muscle, it cannot release. So we can realize that there may be spasms in the muscular tissue connecting to the navis. So if there's a spasm, the navis might slightly dislocate from its position, and or may it affect the organs that are attached to the navis. But what about ligaments? What about fascia? Is fascia and ligaments also able to go into spasm and become shortened? I want to say yes, and this is what it has been mentioned in the literature, because these tissues, including, it's the same as the muscles, also the other connective tissues like the ligaments and the fascia are made up of proteins. And proteins like elastin, collagen, and other proteins. And these proteins, they are also connecting with each other and forming tertiary and quaternary structures. So we have small weak bonds between these proteins that makes the consistency of that tissue. So when water penetrates in between these molecules, it causes swelling and it will cause displacement of these ligaments and fascia. And so we might have loosening of the fascia and loosening of the ligaments, which is called estirha in our literature. And also, if there is a opposite force making these ends reach each other or close into each other, like if there's a underlying spasm in the muscle, the fascia of the loosened the loosened fascia, it will go into each other. The filaments will go into each other and will cause a another arrangement. So we have a rearrangement in the filaments of the fascia and the ligaments. So maybe fascia or ligaments go into shortening also. So that is, it is very interesting that the that Persian medical physicians have pointed out to that the fascia, the ligaments may go into spasm, shortening. So this will also have effect on the organs that are still connected to the navis. So mostly what we mean about umbilical dislocation is a spasm in the surrounding tissues around the navel area. It might be a ligament, it might be a fascia, it might be a muscle, and so on. Okay, so what are the causes? What causes umbilical dislocation? What causes such a spasm? Sometimes sudden mental shock, like a driver reaches a car, or maybe somebody is sitting in a car, suddenly opens up like his or her eyes and says a truck is coming forward, or sudden maybe bombardment, or maybe a loud sound, or something that scares people. It may cause sudden contraction of the muscles. So this sudden contraction in the abdominal wall may stay into shortening and remain in some sort of shortening of these muscles and cause umbilical dislocation. Sometimes unsymmetrical or unusual force to the surrounding tissue of the navel area, like in push-ups and other exercises, sit-ups, push-ups, and other exercises, it will cause such spasms in the navel area. So it's not very good to do such exercises when there's a suspicious navel dislocation. So before that, navel dislocation should be treated. Sometimes excessive damp accumulation in the in cutaneous yeah, under the skin may cause such a problem. Although there is a controversy here. Yes, any points?
Dr. Zed, please say again last sentences. Some second we don't have your words.
Yeah. Okay. I think there was a disconnection in the internet. Okay.
And also you are explaining these facts according to modern medicine science. I want to ask you, if possible, is it possible you may explain something about suspicious, for example, temperaments that can get this kind of problem? Is any of temperament are suspicious to get this problem or not?
Yeah. To make a body susceptible to such a abdominal dislocation and navel dislocation. Yes, I'm mostly talking in the context of from the context of Persian medicine, folk Persian medicine, but I am discussing the probable mechanisms behind abdominal dislocation, like the accumulation of dampness. So in bodies that are accumulated and filled with dampness and balgam or phlegm, as it is well known in humoral medicine, will cause spasms. But although this is somehow a controversy, I know that usually when we think about spasm, we think about dryness and lack of humidity, lack of dampness. But how come a excessive dampness may cause spasms? Okay, but we see this problem, and in my point of view, the mechanism may be so that some of these spasms are we have many types of spasms discussed, or tashannuj discussed in the literature, in the Persian medicine literature. Some of them are due to the dryness. Okay, so the decrease in perfusion or decrease in dampness of the blood or body causes dryness in the muscles, and we have a spasm. But we don't see these too much unless in excessive situations that there's dehydration. But mostly what we see is due to excess of matter, excess of fluid, excess of spilling of these fluid in the muscles. And this causes تشنج امتلائی, a fulfilled, maybe a excessive type of accumulated spasm, that this is due to, because the muscle needs energy, blood, calcium to go into contraction and also to release. So even to release itself, the muscle needs good perfusion. But when we have fullness in the muscle, in the interstitium of the muscle, in the in between myofibrils, and we have excessive fluid, it causes it's a suffocation of the muscle. So the muscle cannot breathe. The muscle cannot be penetrated by enough blood or nourishment. So it causes the remaining of the muscle into its contraction, and that is called a spasm. So excessive fluid over the abdominal area, under the abdominal skin, which is mostly in the Camper's fascia. If you check Snell's anatomy, I didn't get the time to bring that slide about it, but you can see here subcutaneous fat. It melts gradually. These phlegms and or these adipose tissue melt gradually and go into the muscles and makes swelling in the muscles, and it makes spasm in the underlying muscular layers, and also in the fascia. Also, it causes the looseness of the integrity, disintegrity in the fascia and the ligaments, and they go into spasm, obeying the underlying muscle. So let's speak now about the consequences and the adverse effects of naval dislocation. Okay, what happens when someone has one has a naval dislocation or a dislocated navis? First of all, it is rational to think about GI problems, because the navis is a neighbor to the GI system. So it is previously connected to the small intestines. It is connected to the liver, and it is connected to the abdominal wall. And so it may cause pain, abdominal pain. It may cause constipation in some people, and also it may cause diarrhea in some other patients, because it depends on, it's like a liver, the law of the simple machines and liver. So when there is force on some part of that spastic area, it may cause a force on some part of the intestine, and causing the emptying of the intestine, and it may cause diarrhea. But it may cause spasm in other parts of the intestine, and it may cause constipation. So it depends on the part of this and the location, anatomical location of that spastic area around the navis. So the consequence differs diversely, and it's not always in one form. So it also may cause flatus and inflation of the abdomen and the intestines, and it may also cause dyspepsia. But is that all? No. Unfortunately and surprisingly, this is not all. And the effect of this spasm will transmit to other organs, including the brain, including the lungs, including the diaphragm, and including to other systems and organs. So, and I have seen a variety of complications, very interesting relation between these variety of complications with a naval displacement situation. And after we have treated the naval displacement, that complication has been cured very interestingly right away or gradually. So this shows the very amazing connection between the navel area and other parts of the body. So I've seen headache, maybe vertigo, dizziness. I have seen visual problems. I've seen scotoma and blurred vision also, like when I was fixing the navis by twisting the navis, which I'm going to show on a mannequin, how we do that. The patient said, "Oh, there's a curtain going over my eyes." And I went back and the curtain went out, wiped out. So it was very interesting that by twisting the navel area, there was a scotoma or a blind a black spot or blind spot in front of the eyes of the patient. So these aren't something that has been written in the books. This is to be experienced, and it's very amazing. These connections are very amazing. Like you can see many other list of problems by yourself in the future. If you practice, you see many other connections and more amazing connections also. So there's also psychiatric problems like nervousness, depression.
Dr. Alizadeh,
Yes.
It's a question for me that in these neurological problems are due to neighboring of the spasm to, for example, nerves and veins and arteries, or this is a central problem from the brain, or this is the next step of GI problem, for example. What do you think about this?
You mean which is the sequence? Like, is the neurological problem causing the spasm, or the spasm causing the neurological problems? Like the hen or the egg, which was first? Is that your question?
No, my question is, what is the mechanism of neurological problem in your mind? What do you think about the mechanism of neurological problems?
Mostly sudden like stresses, like a fear or a grief, that a person loses somebody, some of his family suddenly. It causes a sudden shock, and this causes vasoconstriction in the femoral arteries, in the peripheral arteries, including the peripheral arteries, or the end arteries of the brain, the end arteries of the limbs, and we have a systemic problem. So after a sudden shock, we have a fight or flight situation and excessive sympathetic release of hormones and mediators that it causes vasoconstriction. And this vasoconstriction causes the blackout or the ischemia of some important organs, including the suprarenal, the adrenal gland, which has effect in controlling stress and in secreting cortisol and other immunomodulatory hormones. So this in the next slides, I have the slide that this such a sudden situation causes many systematic problems, mostly autoimmune problems. Like it causes many systematic problems, including affecting the immune system, and this vicious cycle, the started vicious cycle, which the patient goes into depression, the patient goes into suffering a pain. This keeps that system sympathetic release. It maintains it, so there's an ending to it, and it continues that way. So it affects most parts of the body, including the brain, and also susceptible people, like nervous people, and or those with weak brains, we say ضعف دماغ, weak brains, they are most susceptible, and their threshold is more low to such problems, to receiving such shocks. So it's also like it has effect on each other, like this problem affects the brain affects this problem, and this continues. So we have a vicious cycle. So this is until up to what I have reached, that mostly it is a matter of circulation, and mostly it affects the circulation of different organs and the peripheral organs and the end organs, including the cortex of the brain or the nail of the foot. So and sometimes we have a technique, shadow wrapped. We have some maneuvers we do on the femoral artery and the popliteal artery to open up the circulation of the feet and readjust the gauge of these arteries, but sometimes it doesn't work, and we find out that there is a umbilical dislocation. So first we have to release the umbilicus and to relocate it and to release those spasms, and then we see that the technique works. So prior to opening, prior to treating the umbilicus, umbilical dislocation, mostly you cannot rearrange the perfusion of the feet. So this also it also it's an agreement with my saying that it's a sign that perfusion, blood perfusion is very much affected by umbilical dislocation also, because it affects on the aorta and the also the descending aorta, the femoral arteries, the iliac arteries, and so on.
Thank you.
Yeah. There are many other cardiorespiratory problems that you see in umbilical dislocated umbilical patients, that like hypertension. You do a massage and the hypertension, in some people, although in some people, the hypertension is due to these spasms. So when you cure the spasm, the hypertension goes, okay? But and hypertension that is responsive to medications sometimes vanishes by releasing or a massage that you release these tensions. The shortness of breath. Sometimes when you release the umbilicus, the patient says, "Oh, I can now breathe. I can now breathe more deeply." So the patient feels this ability and this opening in the lungs right away. And palpitation and arrhythmias sometimes have been seen. Reduced peripheral blood circulation and coldness in the extremities. I have already talked about it. And as I said, autoimmune disorders. I have seen dermatomyositis after sudden fear, multiple sclerosis, induced diabetes. A patient falls from a building and suddenly we have a diabetes, induced diabetes, or Hashimoto thyroiditis, sclerodermia. These are different autoimmune disorders that we see with a component of umbilical dislocation. I'm not saying that this umbilical dislocation is causing the autoimmune disorder. So when you might fix that umbilical dislocation, but the disorder is remaining. But it's a complex issue coming up after a sudden shock. And the umbilical dislocation in these situations is a component of a bigger issue, post-shock situations. So, but keeping the umbilicus in its place and removing the spasms helps so much in controlling the signs and symptoms. And altered menstruations like hypermenorrhea or amenorrhea, so excessive or less menstruation is also related to umbilical dislocation. Okay.
Dr.
Now, yes.
Dr. Alizadeh, before diagnosis, it's a question that how much it takes from cause and these problems, for example, from a stress event and from diabetes, from stress and from, for example, Hashimoto thyroiditis, how much it takes?
Well, I don't, because these are only sporadic experiences. I don't have the statistics to say it in numbers, but the spasm usually starts right away, and gradually it causes the malcirculation, and gradually different problems appear, like a week after or 2 weeks later or so on. And sometimes until 15 years, we have a spastic abdomen also, like in such severe cases, like some people who work on folk medicine, they say that this spastic abdomen wall shows that the stress was under 15 years before, like within 15 years from the time of the visit. So, and after maybe it goes into flaccidity or looseness maybe, but we have to do scientific research to figure these answers. So it's just a wild guess, and I'm just guessing about the timing.
In my experience about arthritis patients, for example, rheumatoid arthritis due to stress, when I checked, it seems that 6 months to 1 year before at the beginning of main clinical manifestations, we may find the stress story, the stress event. But I don't know in other patients what is the time. I think that you're right that we have a wide range of time. But I want to say my experience about arthritis patients. Go on, Dr. Elizabeth, about diagnostic.
Okay, now let's speak about diagnostic clues. How could we have the clue that maybe our patient has a spastic or a dislocated navis? So I've prepared a mannequin here to show you the examinations that we have on the umbilicus. Okay, first I said the point about the dislocation is that we should look for spasm. And the first sign of spasm is stiffness in the umbilicus areas within 2 finger width radius around the umbilicus. So we go with 2 fingers, we examine the umbilicus. So this is the costal margin, okay? And this is the inguinal area. And we go perpendicular to the plane. The patient is lying on the floor, so but I have to stand the skeleton up to show you. But so you go like this in the navis and you examine slightly, and then you go above, below, to the right, to the left, and on the sides, like 45-degree angle on the sides. And you get a you ask the patient, how much pain do you have? Like on the VAS scale, visual analog scale, you ask how much pain you have. Like from on the scale. Yes.
Excuse me, because some of our colleagues just see your slides. I asked them in view options, please check side-by-side mode, because Dr. Alizadeh shows something in the knowledge, and you may not see the
check the video, my video also.
Yeah.
Beside my slides, I'm showing visual on the video. Okay, so
view options, in view options, if they check side-by-side mode, they can see you and slides together, and you can see your explanations about in knowledge.
So we when the patient is lying on the floor and the knees are bent, the abdominal wall releases, so we can examine very much better. Okay, so we go 90 degrees in this way, but we don't press too much, only slightly to pass the flesh, the subcutaneous flesh. We go to reach the muscles. Okay, so we press it and we say on the scale of 0 to 10, how much pain you have. Like it says 6 out of 10. And we go above and we ask again and below and to the right and to the left and on 45 degrees angles. So in different, as you may see in the slides, in 8 directions, we check the spasm, the pain, the stiffness. First, the stiffness of the abdominal wall in these areas. And also we ask for the pain. Like, do you have pain and how much pain you have? Okay, so because we are short in time, I'm moving much faster. And so if there is pain by its own, or if there's pain in my examination, so which is called medically tenderness. So if there's tenderness here, if there's a spasm, if there's stiffness. So these are in the 2-finger radius around the umbilicus, not on different parts of the belly, because it has many other diagnoses. It has many other diverse diagnoses. If you go very far from the navis, we're talking about the navis. Although you have to bring in mind other causes of pain and medical acute abdominal causes of abdominal pain, you have to consider them and not to miss them. Okay, so but some people say that this dislocation, it's not really a dislocation in my point of view. It's only very slight. Some people they measure from the nipples, and they measure and they see how much it is displaced. That's it's not needed, and it's not that accurate. So what we are looking for is a stiffness, and if there is ischemia due to that stiffness, we will find some pain or even tenderness. Okay, it's a spectrum of different signs, and some people say that the pulsation of the aorta has been displaced from the midline, but this cannot also happen because the aorta is fixed by the side connections to the spinal column. The aorta cannot be displaced, but the pulsation sensation can be felt more to one side than the other, as you see in this picture, this imaging, that on the left you see the aorta as a cross section of the aorta as that red circle, and the pulsation diminishes when it reaches to the surface. But when we have a spasm in one side, it transmits the pulsation readily, so you feel this the pulsation more easily on one side, and you omit the pulsation. Your brain omits it on the other side, so you feel that the pulsation has been displaced from the midline. So it's just the matter of that spasm that we said. So it's all about a spasm. And we can also examine the plantar area, like reflexology. We know that these parts are related to the abdominal area and the celiac plexus. So if there is a spasm, if there is a stiffness, if there are some button-like structures, there are stiff button-like structures, you feel that, and painful and tender when you examine that part, you also, it's related to the umbilical dislocation. And also in the treatment, we say that when you work indirectly on those points, you may release the abdominal area indirectly. So what are the therapeutic means? Well, how do we treat umbilical dislocation? One is by direct massage on the spastic area. Like when you feel that there's a spasm on the right of the navis, you go there and you, if there isn't any underlying important medical issue, okay, there isn't a cyst there, it may not be ruptured, or you know that there he or she had a sonography, and so it's not a big issue there underlying. So you're
Aortic
allowed to
aneurysm
do
that have,
massage. You go and do the massage. Yes.
I said, for example, aortic aneurysm is important.
Yeah. Different severe medical issues that you're not allowed to press the abdomen, but you don't go it very aggressively, only slightly on the abdominal wall, and you try to pull out these fibers by doing slight ischemia on that area, forcing a slight force and causing a slight ischemia under 2 minutes, okay, not over 2 minutes. It causes the secretion of nitric oxide molecules that it will cause vasodilation, which is called taftih afwah uruq in Persian medicine. We got vasodilation in that area, and that causes local perfusion. More local perfusion, it causes decrease of the spasm. Or maybe you go transversely like this, or in different directions due to the spastic pattern that you see on the abdominal wall. So direct massage is one mean that you can use, and dry cupping you can use with oil. You put oil on the surface, and you can go on the navis and bring it out. You do suction here with the device, and you go on the navis, and then you pull out and you turn it slightly, or you put oil on the around the navis, and you do sliding cupping, and you gradually pull the tissue inside and pull out those filaments from each other. So cupping also is used. So we have short in time. We are short in time, so I have to skip the detail. But thermal administration by these hot bags is also very good in decreasing the spasm there, and plantar trigger point release, as we do in reflexotherapy. It can also be used mostly in patients that are very sensitive in the abdominal area, and they cannot bear any intervention here. You do the release by indirectly by the plantar area. And the umbilical twisting. The umbilical twisting is another option. Sometimes we do it. We go. It doesn't matter which direction, in my point of view, but some people say it matters. But in my point of view and my experience, it doesn't matter. You just go in, and you have to get a grip. So you mostly may, you use a handkerchief or tissue paper to get a grip on the skin. See, this is the skin, and you put a handkerchief here, and you select the finger that fits very good in the umbilical pit very well, and you go in one direction, and you use your space enough around the bed or on the floor, and the tissue, the skin should have a grip around your finger. If it has a grip around your finger and your finger gets stuck there, you're doing it good. Okay, so it needs twisting in this direction. Okay, but before reaching the painful point, you have to stop and let it release gradually. So the tissue releases your finger gradually, and your finger will come out loose. Okay, so then it's time to turn in the opposite direction. So you go until you reach a stiff point that the skin tissue is wrapping around your finger, and your finger is stuck there, but there's no pain, and gradually it releases. It's like releasing muscular trigger points by needle in acupuncture. Sometimes in trigger points, you go by needle, puncture needles, and it holds your needle. And after the release of the spasm, it lets go of the needle, and the needle comes out readily and easily. So you go many times in either direction to reach a non-gripping situation. So you see in either direction, it's not gripping your finger anymore. So that's enough release. But last but not least,
3 minutes you have, because we want to have 15 minutes if anyone have some questions, and I have some questions too.
But the very most important and surprise maybe for you about umbilical dislocation is the umbilical flooding. If there's flooding, if there's excessive phlegm here, you cannot fix the umbilicus very well in the normal to bring it back and keep it in a good situation. It will go into dislocation again because excessive fluid doesn't, it's against consistency. So if you have excessive Camper's fascia volume, like you have excessive dampness here, you have to fix that first. So maybe you relocate the umbilicus and you treat it, but when the patient is going out of the room or going out of the clinic, it's dislocated again. So in this situation, please pay attention to the figure that it's in my slides. You can use first in the mornings, you can use this technique that by hot bag, you fill the hot bag halfway with normal water and then with boiled water, and you tighten the head, and you use hot water centered, hot bag centered on the umbilical area in the morning when the patient is lying on the floor, and the patient does such a motion like a wheel of a car. He or she keeps doing that until he or she feels the heat penetrating inside the abdomen. When he or she feels the heat penetrating, not fully heated, only the start of the penetration takes away the hot bag and does massage from the costal margin to the inguinal area, to the inguinal line like this. 30 to 40 strokes to empty out the loosened jelly, the interstitial jelly that has been loosened by the heat, out of those areas. So you're melting those fat, melting those interstitial stiff jellies, and you're washing it out of the area to let the better consistency of the muscles. And then the patient lies on the tummy and takes up the upper part of the body from the floor, like the figure that you see below. It's like the you see in the here. And if there is there's ability and there's no pain, it could do any of these two positions. Take any of these two positions for 2 minutes. So then he or she can wake up, can stand up and go to start his day. So this is the end of my speech, and accidentally I came across these two figures that my daughter has drawn about the umbilicus, and I haven't talked anything about the importance of umbilicus at home, but amazingly, my 4-year-old daughter has drawn these pictures and bolded the umbilicus and the patient, the guy or the gal feels very healthy. I think because of not having a dislocated umbilicus. So at the end, I want to give a gift to all my audience from the Holy Quran, chapter 49, verse 13, that, O mankind, we created you from a single pair of male and female and made you into nations, races, and tribes, that you may know each other and not that you may despise each other. Verily, most honored of you in the sight of God is the most righteous of you. And God has full knowledge and is full acquainted to all things. So we look forward for a world free of racism, discrimination, violence, oppression, invasion, and abuse for all the children of Adam and Eve. Thank you for listening.
Dr. Alizadeh, thank you. We hope we don't have abuse in the world that are the root of stress that, as you said, one of the causes, and I want to say one of the main clues of umbilical dislocation is the history of stress. And we hope that we don't have no bad stress in the world. In these days, we see some bad scenes in Gaza Strip. I want to ask you, my colleague, to pray for all people in the world, and especially on that place. Anyway, we have some questions. You told something about the measuring between nipples and umbilicus that Dr. Saqib asked. Is it important? You explained something, and I add we can do this with other some places. For example, iliac crest, superior iliac crests. And some other places.
The access point, the anterior superior iliac
spinal crest, process. And would you please explain again? You said that it's not important. The distance is not
the access
important.
point.
Maybe
the access
we have
point
equal, but maybe we have umbilical dislocation.
Because in the access point, the anterior superior iliac spine, it's located on each side, and you can measure as a landmark to measure this this distance with distance, and you can compare these two. But I don't think this is needed, because you have many other obvious signs, and maybe there are anatomical variations in people, maybe there's surgery, maybe it's maybe it doesn't equal, but there isn't any umbilical dislocation. But maybe there is unequal, there is equality, but we have a umbilical dislocation. So it has many false positivity and false negativity. So I say we look for spasm and any signs of spasm, and the first sign is stiffness, and then we have tenderness, and then we have pain and other issues. So when you have pain and tenderness, it's very obvious that you have a umbilical dislocation and you have to go and fix it.
Thank you again, Dr. Alizadeh. I can see some of my dear friends, for example, Mrs. Ghazal Javid from India, Dr. Sharik Khan from Bangladesh, and Dr. Faizeh, and many other of my previous colleagues. If any of you, my dear colleagues, want to say anything, I want to ask my colleague in Tom's open your voice or camera, if is it possible, or if any one of
Okay, we
you
have
want to say anything, or
Mrs. Ghazala Javed. She's trying to open the microphone. I think she wants to have a point for us.
Thank you so much. So nice to see you. Assalam, everyone. And
Thank you for listening and participating.
Yeah. So first of all, I'm thankful to our DG sir. He's traveling, otherwise he would have joined it. So on his behalf, I would like to congratulate each one of you. It was very informative presentation, and we ensured that some of our colleagues can be here and they should benefit. So council's officers are here, and I just noticed that they are there, and they were present throughout the lecture. It was really very interesting, and the takeaway message also very well appreciated. So greetings from CCRU, Ministry of Ayush and Government of India. Thank you so much.
Thank you very much for your kind.
Thank you, Mrs. Ghazala Javid. Do we have any other comments or questions from Dr. Alizadeh about?
So it was all encompassing, and I must say that this problem, which we sometimes feel that it is not that equivalent, the way it was explained, using the video, using the dummy model and project, and showing the association, the holistic approach, that is the main crux of our system, of our Unani system of medicine. So I was very much impressed the way this presentation has been laid down. It has been a learning experience for us also. So I think we should continue on this line, and we should have series of lectures like this. It was very informative. I must congratulate.
Thank you very much. I have a question from you. How much have you approached umbilical dislocation and felt it serious, or worked with it in your context of?
Actually, right now I am, because Dr. Ali Raza knows very well. I am sitting in the main headquarters, and I'm more into policy making and file reading.
Okay.
Yeah. So
you paved the path for the healers.
Yes.
So that's very important. That's very important. Thank you.
And we do encounter such cases, no doubt about it. I can talk from my previous experience when I used to sit in the hospitals and do general Medicare. But yes, exact number I would not be able to give. Thank you.
Thank you. Thank you.
Thank you, Mrs. Ghazala Javid. I hope we can connect together to future programs. It's possible for us in Tehran University of Medical Science. We have joint programs. One professor from Tehran University and another professor from, for example, India or Bangladesh. And I hope you be successful in CCRUM to encourage other professors to have joint programs like this with us. And any other comments?
Thank you so much. Yes, I think that is the way we can move ahead by way of having joint webinars and joint conferences and seminar. We are open to it. Inshallah, we'll plan for it. Thank you.
Inshallah, plan. Yeah. We will connect together, inshallah.
Yes.
Okay. Anya, any other of my colleagues? Dr. Sharaf Khan? Any other? Dr. Sheikh Norris? Dr. Saqib? Okay, we hope to see you again in India or in Iran or any other countries in conferences together. We hope you have a good time in your institute. see you in future programs, inshallah. Bye bye.
Bye. Thank you very much. And thank you, Dr. Abbasian.
One important point. We will have certificates passively, not actively. Anyone who wants certificates should email his identification information to appraisetrace@toms.ac.ir, which are posted in WhatsApp previously. And when you send an email, I want a certificate, they prepare for you the certificate of this program. Have a nice time. Bye-bye.
Bye.